Hey everybody, welcome back to today's video about upper extremity pain and discomfort and problems and how we deal with that. So probably the most common upper extremity issue is a shoulder issue. And shoulder pain can be variable. It can, people come in with front shoulder pain, with pain on top of the shoulder, with pain in the back of the shoulder, with pain coming down into the arm. And so we have to try to differentiate that and see what exactly is the problem. So that's one of the nice things about ART is that there's a whole kind of analog or algorithm that we go through to see what, to diagnose properly. So a lot of the times, not just with the shoulder, but with everything else, where the pain is doesn't exactly mean where the problem is. So with the shoulder, we have muscles that are attaching and coming from all different areas that are attaching into different spots in the shoulder. And the pain may be the insertion of the tendon, but the problem is actually in the muscle in the chest or in one of the rotator cuff muscles in the back of the shoulder. So it's what the shoulder can be a difficult thing to treat and diagnose because there are so many moving parts. And, anytime you do a movement, there's tissues, there are muscles that are shortening, there are tissues that are lengthening. So things are moving all over the place. So to properly diagnose what's going on, I literally stick my hand in there and we kind of feel around and we move the shoulder. Does this hurt as I do this? Does this hurt as we move it this way or this way? And we can feel, which muscles or which tissues aren't moving properly. And then we can go ahead and treat that. So it's one of the reasons that ART is so efficient is that it's a way to actually first diagnose and then treat. We're not just, oh, it hurts here, let me kind of push in there and let's move that around and see if that feels better, because where the pain isn't always correlate to where the problem is. And I'll talk about this in a couple of minutes, but when we get into the wrist, that is a very common issue. But some of the things that we see with shoulder issues are certainly rotator cuff injuries. Now, not complete tears, not a miracle worker. I did have a patient one time, had an injury, had a slip, had a fall, completely tore his supraspinatus tendon, and came in and said, "You gotta fix me." And he couldn't even lift his arm off the side of his body, which that's what the supraspinatus does. And I said, I can't do anything for that. You gotta go get an MRI to make sure, to see what the damage is, and he ultimately needed surgery for that. But, a lot of times people just, I hurt my shoulder, I don't know what I did, there was no trauma, it was, maybe from working out or, sleeping on it, funny, and muscles and tendons and things get tight. Or they say, oh, my shoulder kind of clicks and clunks and pops around. And a lot of that is tendons that are tight, that are kind of gliding over other tendons, and they kind of go clunk, clunk, clunk every time, and that's something that a lot of times we can help with. But certainly shoulder pain is a common thing. Sleeping either on the shoulder or head above the shoulder can cause issues. Those kind of repetitive stress injuries that we talk about often. So we can help a lot of times with that. And again, we can usually tell within a couple of visits whether or not it's going to be beneficial. I'm not going to see someone 6, 7, 8, 9 times if there's no change in their symptoms. And we know we've got to try something else or do something else. But even after the first treatment, I want people to feel different. Whether that's good or bad, a change is always a good sign that we're having an effect on that tissue. Most of the time people feel good, but occasionally people will get sore afterwards, which is, a common thing. So we try to explain that ahead of time. But, we want to see some change, very shortly after treatment. So shoulder issues, all types of stuff can happen there. So it's hard to get into specifics there, but a lot of times it'll also come up into the neck. So we have to treat both. The trap muscle, the upper trapezius comes from the neck all the way down to the top of the shoulder. So, a lot of times we're going to be working on the shoulder and the neck, or vice versa. Someone comes in with the neck and they say, oh, it's kind of coming down into my shoulder. A lot of times there'll be some of those muscle connections that come down through there. So we're gonna treat both of those. Also in the upper extremity, something that we see a lot is elbow issues or forearm issues or wrist issues. So, and you know, people come in with wrist pain or elbow pain, or they have pain that's coming down the back of the arm. And when we try to differentiate, well, is it, what kind of a tissue, what tissue is involved? Is it muscle? Is it nerve? Is it nerve root coming from the neck? You know, nerves tend to have different patterns of symptoms. So if it's following one of those patterns, that's what we go after. But, you know, pain that comes down a certain way in the arm, if it's coming down the back of the arm, that's not a typical nerve distribution that we see. So, but what does come down the back of the arm is the tricep. So again, we kind of get in there, feel around, we move the arm around. Does it hurt when I do this? Does it hurt as I push like this? And a lot of times if it does, we can treat that, and that will alleviate the pain. Or if it's, you know, it's coming down into the elbow, the tricep comes down into the elbow, that's what helps extend the arm. In the forearm or the wrist, people, you know, will complain of, oh, my wrist, you know, hurts like this. And if there's been no trauma, you know, we know it's probably not broken. So we start feeling around, and the muscles in the forearm, this is a good example of the pain or the problem not being where the pain is. The muscles in the forearm come down through the hand and through the wrist. So a lot of times as we feel in through here, we do some checks and some tests here, and we'll say, well, does it hurt there? Does it hurt as I do that? If I hold pressure in that certain spot, does that replicate the pain into the wrist? And a lot of times it will. So if we treat, you know, we can always adjust the wrist. You know, chiropractors do that all the time, and it's something that I do often. But we'll also check, you know, the muscles and the tissues in the forearm. And again, a lot of times it'll alleviate that pain. Another common thing that I see a lot, and again, I'm usually not the first person that people see for this, but it's carpal tunnel. So carpal tunnel is, you know, when we get pain or numbness or tingling or muscle weakness, not just in the hand, but in typically three of the fingers, the thumb, the index, and the middle finger. So this is often self-diagnosed. People will say, oh, I think I have carpal tunnel. And again, we start to differentiate where the symptoms are. Is it, you know, in this part of the hand? Is it in this part of the hand? Is it the whole hand? Where is it? And that can help us, you know, diagnose the problem a bit easier. So sometimes people say, oh, no, I think it's only in these, you know, two fingers, and we know that's not carpal tunnel. That can be something else. Or they'll say, oh, it's the whole hand. And so one of the things I will have them do is when you have the symptom, try to differentiate which fingers you actually feel the numbness or the tingling in. And, you know, just by kind of tapping the fingers, it'll be like, oh no, it is definitely these three. So with carpal tunnel, again, just like sciatica, it can be a nerve entrapment. So typically when the problem here, this is where the carpal tunnel is, right in your hand. And so when you have the surgical procedure, they cut in there and they release what we call a retinaculum that frees and kind of takes pressure off the nerve and the blood vessels that go to what we call the median nerve, which goes to this kind of area here. And that runs through the tunnel here. And if that is really where the problem is, which it can be, and some people certainly need surgery to fix that, but if we, you know, put pressure on there, and if it's sore, then we know the problem, you know, might be there. But again, in my experience, most of the time it isn't. I'll push there, and so that feels fine. But the nerve comes up through the forearm and can get entrapped in some of the muscles in your forearm. So that's again where we start to poke around and feel around and do some checks and do some tests and see how does that feel as I do this, how does it feel as I do that, does that hurt, is that sore, is that tender, and we can, you know, see what muscles and what tissues might be tight or have some scar tissue or have some adhesions in there and might be entrapping that median nerve. In the elbow, we call it the ulnar nerve, so it's the ulnar tunnel, and you can have it kind of under here. This is the funny bone nerve, and so if you ever ding your funny bone, this is the nerve that you're setting off here, and it's going down into these two fingers. So one of the most common things I see for that is people will say, oh, my hands go numb while I sleep. And again, is it the whole hand or is it just the two fingers? Well, maybe it is just the two fingers. And if that's the case, most of the time they're, you know, sleeping with a bent elbow on the arm or on the elbow like this, and it can actually stress or compress that nerve this way, and can cause, you know, the fingers to go tingly that way. And so that's, you know, there's not really much you do about that, but straighten your elbow as you sleep, and that usually will resolve some of the symptoms. But those are stuff that I see all the time that we help with. If anybody has any other issues, questions, concerns, please let us know. Again, we're offering the free 15-minute consultation. If you guys have any problems with something and you want to have me take a look at it or just talk about it, send us a message through Facebook and we will get you set up. Again, we try to get those set up as soon as possible as our schedule allows. We're not going to, you know, set you out in 3 months or something like that, but we'll get you in here sooner rather than later. So thanks for watching this video. Again, come at us with your questions, comments, and concerns, and I look forward to talking about the lower extremity tomorrow. Thanks. Bye.